you, Dr. Hughes. Next on our list, we have Professor Aisling Ryan, Consultant Neurologist from University College Hospital, Cork. And Professor Ryan's talk today is on H90D, the second most common mutation in Ireland. Professor Ryan.
And now, as they say, for something completely different. Thank you very much. I just want to move on, sorry. Oh, there we go. Thanks so much for the invitation. It's a real pleasure and an honour to be here at the first conference, and thanks to Rosaline for reaching out initially and to all the organisers. I'm going to talk about a different genetic variant, H90D, which is a variant that we've seen in the south, in Cork, in a cluster of cases. These are some disclosures. And we've heard a very nice historical talk from Sinead, and many of you here, of course, are very familiar with the Donegal mutation, Donegal AMY. But I'm going to focus on this mutation and describe to you a little bit of the story about how I became involved in looking after these patients and how we found this mutation and some cases that have come through over the years. So before that, I'll just tell you a little bit about Cork University Hospital, where I work. It's a large hospital, it's busy, it's an 800-bed hospital. We're one of 2 tertiary referral centres for neuroscience, so we do 24/7 on-call for neurology. So we get a lot of acute work coming through the emergency department. We do on-call for stroke, we do our outpatients, our day ward, infusion unit, etc. I run a weekly neuromuscular clinic, and I also do a motor neuron clinic, MS clinic, general clinic, because unfortunately we all have to be all things to all people. There are never enough neurologists to go around. And all of my colleagues have their own subspecialty interest. But we're very lucky in CUH because we have a lot of subspecialties. We have pediatric neurology on site. We have 4 neurosurgeons who we get on really well with. We have neuropathologists, one of whom has a real interest in neuromuscular pathology. We have 2 clinical neurophysiologists, and we have neuroradiology. And we're also co-located with a maternity hospital. And actually, interestingly, that generates quite a lot of work and consults, and we're over and back to the maternity hospital quite a lot. So going back to the geography, that's CUH there at the bottom, and we have links to most of the hospitals in HSE South. And you can see there we're linked to Bantry, to Tralee, Limerick, Mallow, Kilkenny, Clonmel, and Waterford. And that's over a pretty wide geographic area, and the population is about 1.1 to 1.2 million. So these are 5 of the 6 current consultant neurologists. This was taken in 2019, and I don't have a photograph of the 6 of us together because obviously we haven't been in a social situation for the last 2 years, so I have to update my slide. So that's Simon Cronin on the left, Brian Sweeney, Anya Merrick, who joined us just in 2019, Danny Costello and myself, and Orna O'Toole is the other neurologist. We're certainly not perfect. Like many situations and hospitals and services, we have a deficit in our nurse specialists. This was some work from the Neurological Alliance of Ireland, who did a campaign recently highlighting the poor number of nurse specialists available in neurology. We only have 4, and we should have 20. And that tells you a little bit about the situation. We have 4 fantastic nurse specialists. I mean, they do absolutely Trojan work, but obviously we could do with more. And as diseases like this increase in complexity and treatment coordination becomes more important, obviously we need more services. So from there, I'm going to tell you a little bit about my very first encounter with my first patient, which was in 2006. And I started work as a consultant in CUH in 2006. And when you start, I'm not sure how it is for everybody else, but when you start as a new consultant, they're a bit surprised to see you and a bit surprised that you need outpatient space and a secretary and an office. And the only outpatient time slot is Friday afternoon, so you have to take that. So this was a Friday afternoon in 2006, and I had a list of patients to see, and this was the GP referral letter. Dear Dr. Ryan, if you could see this patient, and had seen orthopedics and had seen other people, and she was in her 70s and at that time had a 5-year history of fairly rapidly progressive gait decline and loss of dexterity in her hands. And the year previously, she had had a pacemaker inserted. And when I went through the history, she also had a history of bilateral carpal tunnel syndrome. And the GP's letter, which I've highlighted there, just said, oh, by the way, there's a strong family history of muscular dystrophy. And I was going through the history and examining her going, this is not muscular dystrophy, and this is obviously an autosomal dominant neuropathy that's in the family. And, serendipity, this patient's sister was an inpatient under Professor Riley in Queen Square on the day that I was seeing this lady. So chance and coincidence. So I do remember this lady very well. She's an incredibly clear historian, and there was quite a detailed family history. She was able to give a very clear account of the history and who was involved and siblings and her disease progression. From my notes, I had documented that she had quite marked symmetrical distal upper limb wasting, and that she had marked distal lower limb weakness, and she had a classical glove and stocking sensory loss in her hands and feet. So putting that together, and the family history, and the pacemaker in the carpal tunnel, and there was also a brother who had previously had some investigations. There was a note that said somebody found amyloid on a nerve biopsy, but they weren't really sure what it meant. So obviously we were saying, is this familial amyloid polyneuropathy, as it was known at the time? So we did send genetics over to London and came back with this variation in the TTR gene. And the other patient, the sibling, was simultaneously being investigated by Professor Riley. And initially, it was a little unclear, was this a variation? Because there had been another variation described at that site. But as more family members came through, it became clear that this was, in fact, a pathogenic gene. And then the first paper, which Professor Gilmore was involved with here, this was the first publication in relation to this mutation. This was in 2015. And this was describing that initial kindred and describing the phenotype of that patient over in London. And it came about, as far as I know, through a collaboration with the group in Canada, because one of the other patients, her daughter, was affected and lived in Canada and was very keen to progress the diagnosis, and actually sent me a huge amount of information when I was looking after her aunt about the family condition, if that would be helpful. So over the years, I've seen more members of this family, and obviously as new treatments are emerging, people are keen to be seen, and we've seen some people who are affected, some people who are not. And then, again, in a remarkable just incidence of chance, really, I happened to be on call a couple of years ago. I think it was 2017, 2018, and when you're on call, you also see all the consults for that week. So I was asked to see a patient on the geriatric ward who was 72, and the geriatrician asked me to see her, a good geriatrician, because she said, okay, polyneuropathy and postural hypertension is not unusual in their cohort of patients, but she felt this polyneuropathy had progressed quite rapidly over a few years, and the patient was going off her feet. So again, went into the history, and there was a history of bilateral carpal tunnel syndrome, and the patient had a pacemaker, so I went, and we did a through a nerve biopsy, and interestingly, no amyloid was found. And I had explained to my pathologist, I said, I'm really looking for amyloid. They did a really careful study, and they didn't find any. But we did pursue it and did go on and do the genetics, and in fact confirmed that this patient, a separate family, unrelated to the first family, also had this mutation in the TTR gene. So that's sort of how I got involved in looking after these patients, and then we decided we needed to study this a little more formally to describe this mutation, because not a lot was known about it. So I had a really good specialist registrar 2 years ago, and she did a lot of work putting together all the different information from different patients and the neurophysiology and the pathology, which was very, very, widespread. And that's no small feat. As Sinead had said, it's not even easy to know how many patients you have. And if you're trying to deal with IT systems in the HSE, it's difficult to coordinate all this data. So we said we'd try and look and define the phenotype, investigate how much multi-system involvement there was, try and identify any undiagnosed family members, highlighting awareness among family members and obviously amongst our medical and surgical colleagues. So anybody who had a confirmed diagnosis or a family member was looked at, and Marwa, who was the specialist registrar, did detailed chart reviews, interviewed lots of patients, and collected all the data on symptoms and clinical progression, their neurophysiology, biochemistry, cardiac findings, etc. And she plotted out the pedigrees. And so this is the two kindreds that I've described. On the left-hand side is the original large kindred, and you can see that there are 17 members affected over 4 generations. The ones marked or shaded over in orange are genetically confirmed. If you look at the third row, the third generation, you can see with the pentagon there that we don't really have information on those families, but I think there were probably 4 children and several grandchildren, but we don't actually have further information on them. And the other thing I think that strikes me as well is on the far left, you see over there were 8 unaffected siblings. Now, whether they were unaffected, whether they were incomplete penetrance, whether they were later affected, we don't know. We don't have full information. So it's possible, of course, that there are more patients out there. And on the right-hand side, you can see the second kindred, and that's the index case shaded. And that patient has 6 children, one of whom has bilateral carpal tunnel syndrome, and we assume is affected, but they haven't come forward yet for testing or for assessment, despite a lot of encouragement to do so. So we're sort of working on that. So we looked at carpal tunnel syndrome, and this is really highlighting those patients who had carpal tunnel syndrome, and that was documented in 13 of the 19 cases. This is bilateral carpal tunnel syndrome. And it was the first manifestation in 12 of those 13. And the age at onset ranged from 42 to 64 years, with a median onset at the age of 55. And we looked at time from carpal tunnel syndrome onset to development of the more progressive polyneuropathy. Again, quite a wide range from 4 to 26 years, with a median of 9. And also to the development of cardiac involvement. And again, a very wide range, but a median of about 14 years. And this synovial tissue was sampled when you do a bilateral carpal tunnel syndrome release. The surgeon, at least our surgeons, they nearly always routinely send the sample for histology, which is great because sometimes they will pick up amyloid. And it was positive on one, but I've also had another patient who had a bilateral carpal tunnel syndrome decompression. He managed to have that done even before he had nerve conduction studies done, and the sample was sent for histology, and it was negative, but he is genetically confirmed. So there's a lot of variation. So this graphic is looking at the involvement of polyneuropathy, and 15 of the cohort had some degree of polyneuropathy. We didn't really have a lot of information on 6 patients from the older generations, apart from a history of progressive disability and being wheelchair-bound or bed-bound later in life. And those shaded in yellow, we had more definite information and nerve conduction studies available. And the age at onset here, again, wide range from 46 to 73, with a median of 59. And the severity of that polyneuropathy varied quite widely, with some having just mild sensory loss and others with more severe sensory loss and weakness. And from the time of onset of polyneuropathy to requirement of a mobility aid was approximately 4 years on average. And from onset of the polyneuropathy to death, a very wide range, but a median of about 8 years. And we had electrophysiology available for 9 patients. We have 2 electrophysiologists or neurophysiologists in CUH, and one of them, who started a couple of years ago, has particular interest in autonomic dysfunction. So she's working to set up an autonomic function testing lab, which is going to be really helpful, I hope. So you can see there was a variation in the nerve conduction studies, some with a sensory motor axonal polyneuropathy, some with just mild sensory polyneuropathy, others with very minor small fibre involvement with abnormal thermal threshold testing only. We looked at the pathology of the cohort, and we had 4 patients who had had sural nerve biopsies, and the time from onset of a symptomatic polyneuropathy to the performance of a biopsy ranged from 4 to 10 years of those 4 patients. But all 4 of them obviously revealed severe axonal loss and virtually complete loss in one sample. And 2 of the 4 were positive for amyloid. And in one of them, and this was one of the early patients, one of the first index cases I saw, there was immunohistotyping was done to confirm that it was a transthyretin amyloid on the biopsy sample. And that's shown on this picture. The pink is a histology slide showing a little nodule there of pink material which stains up red. for amyloid under the microscope, and then you see this, what we like to say, the classical apple green birefringence under polarized light, which is that sort of apple green color, which is the amyloid showing up under the microscope. This is a patient who gave me permission to use the slide. I actually saw her quite recently. I hadn't seen her for about 2 years because of COVID, and things had progressed significantly. She had been wheelchair bound already and is resident in a nursing home now. But I was very struck by how significant the progression had been, and this shows you the severe distal wasting in the arms and in the hands, and the very, very marked weakness and atrophy of the hand muscles, which has obviously led to huge functional disability and implications for her. So moving to the heart, and I know there are lots of cardiologists here in the audience, and there was sort of an idea, I think, initially when we came across this mutation, that this was the one with bilateral carpal tunnel syndrome and a bit of neuropathy, but we're not really sure how much it does. But we did look at cardiac involvement, and all patients over the age of 60 who had available medical records had cardiac involvement. The age of diagnosis, again, varied from 64 to 76, so definitely later onset cardiac involvement than the neurological phenotype, with a median age of 73. All 6 patients had heart failure, and functionally ranged from the New York Heart Association classification of grade 2 with mild dyspnea to grade 4 with overt signs of heart failure. And cardiac conduction abnormalities were also a feature, and two patients had a pacemaker inserted. One had symptomatic first-degree heart block, and another had atrial fibrillation. And we looked at time of onset from cardiac diagnosis to death, which ranged from 2 to 9 years with a median of 6. And we've one younger patient who has a slight abnormality of conduction, but has had normal cardiac imaging to date and is under close follow-up. 6 patients had left ventricular hypertrophy on their echocardiogram, and the ejection fraction was preserved in all but 1, and that patient also had coronary artery disease and had a myocardial infarction. There was mild to moderate atrial dilatation in most cases. Just one of my patients so far has had a cardiac MRI, which shows the late gadolinium enhancement, which is shown here on the top right. And we also looked at some cardiac biomarkers just available for 4 patients. So certainly there is cardiac involvement. We looked at autonomic involvement and GI symptomatology, and I suppose again trying to determine is this mutation a multi-system pathogenic mutation, and similarly all patients over the age of 60 had some degree of GI dysfunction. And autonomic dysfunction. Urinary symptoms were common, with difficulty voiding and some with urinary frequency. Flatulence and constipation was very common for some patients, with alternating with diarrhea. Dysphagia in 3 patients, and one of the patients required enteral feeding with a gastrostomy tube. Dyspepsia and gastroesophageal reflux disorder was also present in several patients. And one of the patients had a recurrent gastric outlet obstruction and had surgery, and the pathology there showed a lot of adhesions of nerve trunks surrounded by a lot of fibrous connective tissue. Didn't confirm amyloid on that histology. In terms of orthostatic hypotension, and obviously that can be a very prominent manifestation for some patients, only documented in 2 of our cases, but we think that was probably underreporting because either it just wasn't looked at or wasn't documented. In terms of erectile dysfunction, it's only documented for 1 patient, but again, may not have been asked about, may not have been documented. One other thing that came up in our cohort was just 1 patient had a seizure at the age of 73. This was a patient who had a severe neuropathy, also had cardiomyopathy and dysphagia, so multi-system disease. Had the routine infectious metabolic causes to look for a seizure and no other obvious cause found. Had a CT brain showing microvascular ischemic change. And at the time, this was put down to, probable vascular etiology. And maybe it was. You're sort of allowed to have a once-off seizure if you have some microvascular disease in the brain. But I suppose there are increasing reports of central nervous system involvement in transthyretin amyloidosis and leptomeningeal involvement. So I suppose it's certainly worth keeping an open mind about, CNS involvement and other manifestations, particularly as we may see a phenotype change with the new treatments and people living longer, this being now hopefully a chronic disease rather than a fatal one. So if I was to summarise our findings for the H90D mutation, the most common manifestation is bilateral carpal tunnel syndrome with a median age of 55 years. The polyneuropathy is present and tends to be later onset, more progressive. That has a median age of 68 years. We found cardiac involvement with cardiomyopathy, and the median age for that was, do I have the median age? Yes, 73 years. And the cardiac involvement was one of the most serious or significant predictors of death within 6 years. Lots of GI involvement, which kind of was previously unrecognized, I guess, with this mutation, and autonomic dysfunction. So how does that mutation compare to our other mutations which are known about and we've heard about? Most people here know a lot more about T60A than I ever will. So I suppose the difference with the H90 or H110D variant is the classical CTS onset with late progression to polyneuropathy. There is a cardiac phenotype and there is a GI phenotype associated with it later on. And the onset of the late progressive neuropathy is certainly when the disease is accelerating, and we looked at it in our cohort from time of onset to neuropathy to death is approximately 8 years. So I suppose presenting all these findings and looking at this mutation, there were some difficulties in accessing the information. This is a retrospective study. We did this through looking back through hospital charts, written records, patient interviews, and we're relying on patient accounts. But in general, my experience is people and patients involved know a lot of detail about this and the family members, much more so than the doctors who write the family history in the chart most of the time. I do think the prevalence may increase. We have only identified 2 families to date, but as you can see, one of them was just serendipity, and that patient may have gone under the radar if we hadn't sort of pursued it. H110D is a pathogenic mutation and does have multisystem disease, and the phenotype is typically your bilateral carpal tunnel with then late onset progressive polyneuropathy. The fact that there is a temporal relationship between or a time window between the onset of the carpal tunnel and the polyneuropathy and or the cardiomyopathy obviously means that we have an excellent window for therapeutic intervention at that point. So I suppose finally I would say that this is another TTR mutation to consider in patients of Irish ancestry. There are opportunities for early diagnosis and hopefully for intervention and treatment. We certainly still have some barriers to overcome in terms of diagnosing patients and in terms of the management. I certainly could do with more multidisciplinary reinforcements from a nurse specialist. We have excellent occupational therapies and physiotherapists, but the access to them is really limited. There just aren't enough to go around, and I know that's a story replicated across most hospitals. Access to genetic counselling can be difficult. We do a lot of the genetic counselling ourselves in the clinic. And I think there's a job of work for us to do as clinicians to educate our non-amyloid literate colleagues, if you want to put it that way. I think some of these patients may be sitting under the care of the geriatricians, and they've got some heart failure and they've got a bit of postural hypertension, but the sort of amyloid light bulb hasn't really gone off. And I do think there are probably cases out there that we don't know about. In terms of our hand surgeons, as I say, usually they do send histology, and actually just a couple of months ago, one of our he's an orthopedic surgeon, hand surgeon. He does most of the carpal tunnel decompressions, and he said, Aisling, every couple of, maybe 1 or 2 a year, I get some amyloid on these biopsies. Should I be doing something about that? And I said, well, actually, if you wouldn't mind sending them my way. So we've been doing that recently. And among our general kind of medical colleagues and surgical colleagues, just awareness of this. And ultimately, obviously, providing access to the right treatment in a timely way for every patient. So I would like to acknowledge a few people before I finish up. A lot of this work was done by my specialist registrar, Dr. Marwa Assad, who's the real brains behind the operation, and she did all of this detailed data gathering and work, put it all together in a really good, coherent fashion. Our neurophysiologist, Dr. Brian McNamara, the only consultant clinical neurophysiologist appointed outside of Dublin for many, many years, if you can believe that. And he's delighted because he now has a second colleague, Dr. Jennifer Deneen, and Jennifer is an expert in autonomic neurophysiology, so as I said, she's hoping to set up an autonomic function testing lab in CUH. I have two excellent neuropathologists, Dr. Niamh Birmingham and Michael Jansen, and that's Niamh pictured here. Niamh has a particular interest in neuromuscular disease and is really, really helpful when we have a biopsy or there's any sort of, suspicion of it. She will, go to the nth degree to see if there's amyloid present. And Dr. Peter Carney, who's been super helpful, he's our consultant cardiologist, and he has been my sort of cardiac link and for all of these patients. And finally, to all the patients who participated, gave of their time and allowed us to present their cases. So thank you very much.